Hello, welcome everyone to the next podcast of Beyond the Surface. I am so excited about this guest because, people oftentimes don't realize how critical surfaces are. In fact, I shared prior to our recording here with Justin today that I was in a meeting yesterday and I actually had someone say to me, Linda, I don't understand what surfaces have to do with EVS cleaning and disinfection. And I'm so excited to welcome my guest today. His name is Justin McKay, and he's with Rad Care Services. And most people that I talk to have a story. And so I'm going to ask Justin to introduce himself and then to tell us his story. So welcome, Justin.
Linda, thank you so much for having me on this program. I've been so excited this morning to speak with you. You and I could go on a long road trip together and not have any silence together. I promise you that, because we're equally passionate for the right reasons. And it's a pleasure to be here and to speak with you. And my name is Justin McKay to your listeners, and I'm the co-founder of Rad Care Services. And we are kind of the world's only total solutions platform for all things X-ray garment and lead apron. And Linda, just a quick background for you on kind of how that originated or where that started from. I worked in the orthopedic capacity in the OR for a number of years, wearing shared lead and hospital-owned thyroid collars, and I got ringworm on my neck. And it was an interesting couple discussions after that. I went to talk to the surgery director. I said, hey, do these things ever really get clean? These are gross. They're nasty. They smell like cologne, perfume. They're covered in who knows what. And the surgery director said, hey, man, I think radiology is in charge of our lead. Go talk to radiology. And I went and talked to radiology, and I really didn't get a good answer there either. So right out of the gates, I've got ringworm on my neck. I can't go to work, for 10 or 14 days or whatever it was. And then from the hospital side of things, when I'm asking about, hey, what are we doing here? I kind of got a lot of finger pointing, like, I'm not really sure here. It was like everyone's favorite hot potato topic to talk about.
And nobody wanted responsibility for it, right? Nobody wanted to say, "Oh, we're cleaning those." In fact, they
No,
were cleaning them, right?
it was remarkable, Linda. I mean, I went as far, I talked to like radiation safety, and radiation safety explained to me, hey, we think it's probably a good idea. We probably should be doing this. But hey, from a Joint Commission regulatory standpoint, this is what we're required to do. We have to have a log of all of our garments. And so you're right. Nobody really wanted to take ownership. And if you talk to the physicists, they didn't want to touch them. And it's just kind of an interesting situation from the start. I spent about a year traveling extensively for work. And so I'd go to Texas and Boston and Florida and different places. And I spent an extra day or a day and a half on my trips just asking around, talking to whoever I could. And no one ever in a year and some change said to me, yes, we have a program. This is what we do. This is why we do what we do. And here's our record and log. So it was pretty baffling to me, but it also kind of lit a fire inside of me that this was an opportunity to drive some pretty big change in healthcare.
Definitely. So people often don't think about the lead aprons that you wear for hours, right? I mean, when you're in an operation, you're actually wearing these for a long period of time. And let's talk first about materials, the type of material they are, and the instructions for use. Do the manufacturers actually have instructions for use that give guidance as to how often you should clean these and with what?
Great questions. Wow. I got to keep this concise. I have a lot to say on this for sure. Yeah, it's super interesting. In like 2014, I think the first article in OR Manager I found on X-ray garments was from a peri-op director who said, hey, I contacted all the primary manufacturing companies and I asked for cleaning recommendations and I asked for IFUs. And the report that she gave was kind of like, these people said to use Palmolive and these people said to use Febreze. And she was very frustrated because she couldn't get concrete direction. And she had SSI problems she was seeking to remedy. And so initially I read that. And then, Linda, I spent the next year traveling to the garment manufacturing companies. And so I toured the plants and I spoke with their head engineers and their chemists who were making this core material. And so I was asking, we're talking 2013. I was asking, how do you recommend these be cleaned? And the deer in the headlights looks crazy, and I heard the same answers. A mild dishwashing solution and a fingernail brush. You're not going to clean 5,000 aprons like that. One of my favorite conversations I had, they said, we really like to sell X-ray garments. We're not really too interested in the cleaning and maintenance piece of it. And they said, here, you know what? We actually sell this wipe. You should buy this wipe from us and use this wipe. And so I read the label on the wipe, Linda, and it had alcohol in the wipe. And I said, wait a second, an hour ago, you guys told me that you should avoid bleach and you should avoid alcohol. And now you want me to buy your private labeled wipe that has alcohol in it. It just doesn't make sense. So from an IFU standpoint, no, there's not been a lot of good direction given to hospitals. And so literally we had to seek out to build a best practice where we could utilize standards and have testing in place to document for the hospital. This is the condition of your garments when we saw them. This is now the condition when they come back. And the last part, sorry, I know I'm talking long. You asked about the type of materials. So think about nylon. Nylon is the traditional covering of an X-ray garment. It's a porous surface. It is a breeding ground for biofilms. And biofilms love nylon. How about embroidery on the nylon? What a nightmare that is. And so, as you know, you've written articles and journals for years on this. When biofilms start to accumulate and grow, and they secrete enzymes and they start to get tougher and tougher, they love nylon surfaces. And so when a hospital says, oh, I think we wipe them down once a year, that's kind of how we clean them, I'm like, oh man, you're really not cleaning anything.
Yeah. And talk about cross-contamination,
Oh,
because as we know, biofilm grows and grows and grows, and eventually it disperses in the air, but it also touching it and moving it to other things that you're touching. So when you're in an operating room situation, you've got a lot of cross-contamination on patients, on other devices, etc. So people often don't think about that critical component. So when you started to make some changes or write your standard operating procedures, tell me what direction you started in when you did that. So did you start your business first, or was this sort of work you were doing just prior to starting your business where you actually do the cleaning and repairing, etc., of the aprons?
yeah. According to the business gurus and the Harvard MBAs, I did everything backwards. And that's the story of my life. My business partner, my co-founder, he and I were both working full time in the orthopedic capacity when we started this. And I quit my job as a VP of sales, cold turkey, and dove in full speed, which he said, please don't do, please don't do. And so it was a rocky start, because if you can imagine, Linda, the first 2 years of what we were doing was a lot of education. And so my first 2 years, I didn't have a paycheck. We had a baby on the way. I was living off of savings. And at one point in time, he had to pay my mortgage a couple of times because in the early days, people said, wow, I've never heard of this before.
Yep.
Okay, well, what do we do now? But to develop that best practice, Linda, I was very fortunate in the last. I kind of had a mentor. She was a 30-year infection control director who taught me a lot and was very patient with me. She taught me ATP testing. She taught me biofilm formation. And wow, did I learn a lot from her. I also spent some time in Lubbock, Texas. And there's an advanced wound care center in Lubbock, Texas, where I was able to study and learn about biofilm formation and biofilm eradication. And so it's how we set our program up to where cleaning, a true cleaning, is the first step. And then we utilize ATP as a verification mechanism and a quality control rubric to ensure that we've cleaned properly before the garments can then be disinfected. And so I've been doing this all the CDC, the AORN, you know this. They'll say you cannot disinfect a contaminated surface. And so we had to build a best practice, which was different. And we were swimming upstream because we were telling hospitals, guys, there's a better way to do this, and let's do it the right way.
And so now you've created a standard, and are they implementing them, or are you still swimming upstream as you talk to people about the issue?
That is a heck of a question. You and I could talk for 2 hours on that question, Linda. Don't ask me that question after I've had a beer, by the way. No, listen, healthcare has done a really nice job in the last few years. Linda, the light bulb is starting to go off. And when garments have been serviced, they physically look different. They smell different. The torn straps, the broken buckles, all the human hair that accumulates in all the Velcro. The garment comes back. It's like when you pick up your dry cleaning and you're like, wow, okay, this looks sharp. And so I'd love to tell you, Linda, that everyone is on board and everyone is open. I still have a pocket or a handful of facilities and networks that will say, yeah, we know it's probably the right thing to do. And we know you're working in 43 other states, but Joint Commission's not requiring me to do it. And so I don't know if we can afford this. And that's what makes my skin crawl. And that's why I work right now as hard as I do. Now knowing the amount of patients that I do that have an HAI or an SSI who 10 years later are still dealing with MRSA.
Yeah.
And so when a hospital facility will tell me, oh my goodness, that's $20,000 for the year. Oh, we didn't budget for that. And then I see the CEO get a $15 million bonus at the end of the year. I'm not going to sleep until I know, this is like a patient safety, but it's a staff safety issue too. So I'm very passionate about those who are a little slow to come to the table. They better watch their rearview mirror because I'm not going anywhere.
That's really good news because this is a really critical issue. People just do not understand how critical the surface is, and understanding what the surfaces are and understanding what they are harboring. And it is a constant um, call to action to say, let's do some testing so that you understand what the issue is. And then let's talk about cross-contamination and how the contamination that is on a lead apron can be transmitted to a patient in an operating room, it costing them altered lives or even their life, period. Um,
Correct.
and so
Correct.
that is such a critical piece of the education. And then the other thing, one of the things you said was that Joint Commission doesn't require us to do anything differently. And we get this so often. I've had phone calls with medical device manufacturers who say, well, we passed FDA 510(k) clearance,
Right.
use this wipe on the test. Well, in real world healthcare settings, it's not that easy, is it?
Yeah.
And we're killing microbes, and not all microbes die in the
Yeah.
same way with the same disinfectant. So there needs to be flexibility. Talk to me a little bit about, so you had one manufacturer say, here's our wipe, use this wipe, which probably became part of their IFU, putting that in the hands of a healthcare professional who knows they have to kill C. diff, for instance, with an alcohol wipe, which doesn't happen.
Yeah.
What are manufacturers doing now? Are they starting to pay attention? Are they testing for validation of cleaning and some of those things, or what are you running into?
The manufacturers right now, they've got their hands full. And so what I'll share with you there, by the way, I play nice in the sandbox with everyone
Yep.
from the manufacturing space. But I will tell you, we do repairs and we do an annual x-ray inspection and we clean. So I'm quite familiar across the board with who's making what in terms of quality. And so there's been some issues with China freezing some exports of raw materials. That's caused a lot of changes in the core material that's being used. There's currently a national recall underway with one of the larger manufacturing companies due to some quality concerns. So the cleaning piece has kind of always been on the back burner or the back seat with the manufacturers. And, I'll share that now they're engaging in some conversations. They'll put like a link on their website, for cleaning recommendations, go here. I think maybe they've got their hands full right now with the actual manufacturing piece. So the cleaning piece continues to maybe not be an A priority for them. And so for us, we have just tried to really be as vendor neutral as we can, but really just pro hospital and pro patient. And so like we developed our protocols and our recommendations, and we have science and data and ATP, and I've got 13 years worth of research just to share with the hospital. Listen, you're not getting good directions from the IFU coming from the manufacturer. What you are getting from me is before and after data, ATP data, a cloud-based inventory log, compliance records for Joint Commission, disposal, the whole best practice solution. So really the manufacturers have been a little hesitant to engage. And so we've just downshifted and said, we're going to develop the solution and we're going to provide it to the hospitals. You mentioned, the manufacturers' IFUs. We've talked about what I saw and heard in the field. And you started this call out by saying, I can't believe I had this conversation yesterday where she said, Linda, how does surfaces come into play? And I'll never forget, I was in a very good cross-functional meeting, infection control, risk management, OR, cardiology, radiology, all these people at this table in a very well-known hospital system. And they said, well, to the infection control, they said, let's see our protocol, put the protocol up on the screen so we can see what our protocol says. And so she puts the protocol up on the projector overhead, shows my age. I just said projector. And it was a CaviWipe. And so it says use CaviWipe once a month on X-ray garments. And then you read the CaviWipe label, which I had in my possession, stainless steel table use only, use on hard, non-porous surfaces only. And so the risk management person and the legal people were freaking out. Hey, this is they were HFAP. This is an HFAP violation. Oh my gosh, we can't do this. And to her defense, she said, this is what the manufacturing companies told me to do.
And you do know that hospitals are fined if, so surveyors will come in, they will ask how they determined how to clean the document. They will ask for the IFU for a reference. They will look at the IFU. And if they're not following that IFU, the hospital is fined.
Yeah.
And you just described a perfect example of why this law needs to be changed.
Yeah.
Or why it needs to be rewritten and reorganized, because manufacturers, at least the ones that we've been working with up to this point, oftentimes do not understand what is happening in a hospital setting. You can't say that about all of them. In fact, there are some manufacturers that actually have infection preventionists right on their staff that helps them with that. But there are product manufacturers out there that do not.
Yeah.
And this is a perfect example. And the other thing I'm learning about the manufacturers is that the design and innovation happens in one area, and then the writing of the MSDS and IFUs and everything else happens in a completely different space, a long way down the road from the design. And so when you don't have design communicating with, the people writing the IFUs, and you haven't had input from the healthcare facility on what their needs are as well, oftentimes the designs are flawed.
Oh,
And
oh
we need
yeah.
to look at this. I mean, we
Oh,
need to pay attention.
oh, Linda, you and I'm telling you, we're taking a road trip sometime. I'm, I'm, I'm itching to tell you this. So, oh goodness. So I go on site, right? I go to a very large, well-known manufacturing plant. And I go on site and I'm observing the manufacturing process. And that is, it's an open air environment. It's 90 degrees in there. I've got my Mountain Dew, you've got your earbuds, and we're sweating, and you're running the sewing machine, and your friend over here is running the putting the trim on. I'm sewing buckles on. So I've got 10 sets of bare hands that are touching these garments
Yep.
on 10 different warehouse surfaces. Okay. The garments are migrating down the line. They get thrown in a corrugated box. Okay. Sometimes with a bag, sometimes with no bag. They get put in a corrugated box and they get sent right into the hospital. Now, when you ask me if the hospitals are on board with what I'm doing, 60-40. My favorite thing that is why I'm losing my hair is when they say to me, we just bought new garments like last year. They probably don't need to be cleaned. And so people get a brand new garment at a hospital. They open the box and it goes right into a sterile environment or right into a semi-sterile environment because it's assumed to be cleaned. And these garments aren't made, Eli Lilly is manufacturing pharmaceuticals in a clean environment. you know, these are assumed. So in the early days, just to prove my point, I was I was hanging out at the shipping and receiving dock with my ATP, and we were pulling garments right out of the box, and I'm like, "Ooh boy, you know,
Yep.
don't don't take this into a sterile environment."
Yep. I always say what you can't see could kill you.
Yes. Hey, I read your about me, and I wrote it down because it was so good. And you said it's not enough to learn every physical characteristic of a surface or become an expert in disinfection agents. You said the data must be combined with an understanding of microbiology.
Yep.
And that is spot on. And so when hospitals say, oh, we clean them once a year with our own wipes, or hey, we just bought them last year, they should be pretty clean, we should be okay. I've been doing this 13 years, so it's hard for me not to be exasperated to say, give me a break, you know,
Yeah.
wake up.
Yeah. And the challenge for us and in our roles and our goal to educate, educate, educate is always an interesting process. I've been doing this now for 20 some years, and it always seems that around the corner there's one more person you've got to get on and on board to truly understand that. Let's take a picture of this scenario. Let's see how many times these products are touched, moved, come in contact with the patient. One of the challenges we're having right now is around the terminology of cleaning high touch. Will you define high touch for me? And how did you come to the decision that they were high touch? And now I want you to sit in a room and observe what's happening. And people are shocked. And one of the other things I always talk about, I had a call the other day. I said, if you focus on high touch surfaces, you miss the highly touched surfaces because there's
So
no
good.
such thing.
Yeah,
It There's no human behavior and the way microbes move. There is not a highly touched surface that if you clean that, you're going to be safe. So
it's so good. That's
yeah,
so good.
yeah,
We were in New Orleans for AORN, and so we were at the National Surgical Conference. And so the AORN, they write a best practice recommendation every year, which is widely adopted throughout the surgical environment, as you know. And so I talked to a few people there from AORN, and they told me of this study in 2017 where they pulled 175 surgical techs, and they said 80% said, yeah, we wear dirty stuff every day. And 50% said, yeah, we don't have a cleaning program. We never clean them. And then to your point just a moment ago about microbes, she said, of those that we polled, 65% said the garments come into contact with patients every shift. And so the data and the science tell us there are microorganisms quietly hiding on lead aprons, and they're touching patients every shift. That
exactly.
is crazy.
Yep. Well, on that note, we are out of time, which is hard for me to say because, like you said, we could talk for hours on this subject. And I'm looking forward to getting this recording out. And, we have a lot of work to do, and I look forward to spending more time with you and working together on our mission because we're starting to grow quite a group of people that are on the train moving this forward so that people become aware of how critical surfaces are, and in particular on this call, lead aprons.
Well, you've done a wonderful job. You and a couple of your wonderful peers are leading that train, and I'm certainly thankful to be maybe the seventh or eighth car behind you, but I'm in line with you too.
All right. Well, great. Well, thanks again, Justin. It's been a pleasure chatting with you.
Yeah, thanks so much for having me, Linda. I appreciate it.
The ISSA healthcare platform has launched. On the website, you will find all kinds of things, blogs, resources, training information, workshops. Stop by our website. It's issa.com/healthcare.